Kia ora and greetings. My first responsibility is to acknowledge the Galagal people of the Aurora Nation and their traditional ownership of this land and their hospitality for allowing us to meet on this land today. I also want to thank the organisers for inviting me to participate in this conference. I've enjoyed the speakers so far today. So I'm daring not to have any PowerPoint slides while you're all in your postprandial phase, and I know that's a very dangerous thing to do, but here we go. I think if we had to ask ourselves why are we here, besides the if we need our points, we're probably here for some points, but otherwise we're here because we want a better health deal for our peoples. And in saying that we want a better health deal for people, for our nation, we have to acknowledge inequities in health outcomes, and especially the gap between the health of Indigenous peoples in our nations and those of non-Indigenous. We have to also acknowledge that health workers, like ourselves, and health systems are implicated in the gaps. If we don't know that, we should read the early work of the Institute of Medicine and the work of the World Health Organization Commission on the Social Determinants of Health. However, I do acknowledge what someone has said this morning, that it's very rare for health workers to get up in the morning and go to work and want to do harm and to discriminate amongst their patients. Most want to do good, but are we doing it right, is the question I want to ask. To reduce inequities, we need the sector to acknowledge its role. We need to commit to cultural safety and cultural competence, and we need to further develop the Indigenous workforce. In all these areas, we can probably give ourselves small ticks, but not really big ticks. And there has been and continues to be some pushback and resistance amongst our colleagues. So I think I want to talk to you this afternoon about 3 urgent tasks. The first one is sorting out our discourse about intervening for equity. Our challenges with cultural safety I'll briefly touch on, but mostly I want to spend some time talking about Indigenous health workforce development and what it means in the postgraduate space. So in terms of task 1, sorting out our discourse about interventions, there is an anti-discourse about equity. And there's a deliberate development of confusing interventions for equity with privilege. Yesterday I was teaching some students about inequalities, about inequity, and of course I used the analogy of the Titanic. And when we note the disproportionate death rates on the Titanic of men and third-class passengers, I asked them, was it the Y chromosome that was at fault for the higher male death rate? Are men just badly behaved? They won't follow instructions. And I asked them to think about how often we turn to in health genetic and behavioural reasons for differences in health outcomes. These are, of course, superficial causes, and we're very reluctant to look deeply at the structural barriers and the socio-cultural causes, which were the most important reasons for the differential death rates in the Titanic. We've all seen the movie. We know those gates were locked, even if the shipping company denies it. Leonardo told us. We know that chivalry was not dead, especially for the second and third class passengers who had a higher rate of males dying, mainly because of women, the social mores of women and children first. And so we do not believe that it was the Y chromosome on that occasion that was the causal influence in the death rates. So we need to, so I asked the students, what if I wanted to put in an escalator from the third class cabins to the lifeboat deck? The first and second class passengers wouldn't have access to the escalator Hey, they're already on the lifeboat deck. Look at the deck plans. And if we attempted to do that in this day and age, we would be told that it's privileging the third-class passengers because not everyone could access it. And I don't know about here, but in New Zealand, it's sort of everyone has to have it. Otherwise, it's unequal as opposed to equitable. And we would start labelling it as third-class privilege to have access to an escalator, even though you don't need one as a second or first-class passenger. So we've got this problem in our discussion on equity, and that is we're mislabelling privilege as an intervention. And we are actually naming it as privilege when it actually is levelling. So I want us to, when we hear the discourse of people talking about intervening in inequities, we hear the discourse about privileging, we should make sure we have an analysis and relabel it levelling. We very rarely talk about privileging, but it is, of course, the flip side of inequalities, of inequities. We'll talk a little bit about that later. The second task is the challenge of cultural safety. Now, I can hear the sighs already. There's two schools of thought. One is, probably sometimes they're not even thought, they're spoken out loud. One is, this is political correctness gone mad. I treat all my patients the same. And it's wrong on so many levels. The evidence, even if we are going to talk about data this morning or not, the evidence is surely there that we don't treat all our patients the same. We have implicit biases and we act on those implicit biases despite our best intentions. And we work in health systems which actually enable our explicit biases to be operationalised. So that school of thought needs a lot of work, but I wonder how many of people with that school of thought belong to our colleges. The second school of thought is, are we there yet? I did a course, I read a book, I read a pamphlet, I saw a movie, I did an hour's program, I attended a lecture. The desire for a brown tick, a pill, a vaccination, a one-off, hopefully short course that will fix me, I can put it on my CV as done. We need to accept the fact that we have to change the way we think and the way we do. Cultural safety and cultural competence are not the same as an Indigenous health curriculum. They are different. Cultural competence is about me, about my implicit biases and what drives them and what I can do to audit how and if I treat all my patients the same, who I make assumptions about and who I treat differently and what I can do about that. Now, I've got a special power. I can read minds. And I know that some of you, when we're talking about that, we've got to change the way we think and do things. Some of you will think, oh, that's hideous. I can read your minds, and some of you are thinking it now. But it really doesn't mean that we all have to become rural Indigenous health workers, but we all have to be part of the solution in some way. We all have to be great doctors, provide great training, provide great mentorship, and we all have to understand how we fit into the total picture. We have to make sure that we are connected to the solution. Finally, I'll get on to my third task, which is about Indigenous health workforce development. We all have a role in the full development of the Indigenous medical workforce. It's not a needs-based thing. It's not because we have a gap. It's a rights-based thing. Every child, every family has the right to dream to be a doctor and be able to, if that's their passion, be able to see a pathway where they can achieve that. It shouldn't be stamped on. It shouldn't be absent. It shouldn't be taken away from them. It is a rights-based issue. Besides rights, there is evidence that Indigenous doctors will help improve the health of Indigenous people. And that the evidence is around ethnic concordance, meaning that there is often, but not always, less bias in the diagnosis and management of Indigenous patients. In order for us to be able to fulfil our role in Indigenous medical workforce development, we need to understand the structural and cultural barriers. And I want to reiterate that it's not just about a medical workforce. Participating in a career such as medicine will have an incredibly powerful intergenerational community effect. But it will take time. I'm going to fess up that 40 years ago, I was in second year medicine. I started in the University of Otago, and I was one of 4 Māori in the class. 3 completed medicine. And after my third year, I was able to, because of a family tragedy, transfer to Auckland. It was also enabled by the fact that the 2 people who had gone in, I was turned down from Auckland, they'll live to regret that. The 2 people who had been recruited instead of me had not succeeded and had not been retained in the class. And so I became the sole person in the 4th year medical class in Auckland when I transferred. So at that time, 40 years ago, there was between 1 and 4 Māori students in the class, and there was not great retention. 10 years later, the classes had about 8 to 10 Indigenous students, and the cohort effect was a bit stronger, but again, retention and success was not great. After 20 years, the numbers in the classes grew to about 10 to 20 in each year, and starting to get better retention. And this year, there's between 30 and 50 Indigenous students in each of our classes. And this year, Otago is, with its class size of 30, is graduating for the first time 50 Māori doctors. In Auckland, with our class size of 280, we will be graduating 30-something doctors, depends on the Board of Examiners at the end of the year, we say. Now, what have we had to do to change that? Well, first of all, we've had to take 40 years. And when Australian medical schools freak out when they hear what we're doing, they go, oh my God, they want an instant. You have to take the 40 years. Maybe shave a year off every decade or a few years off, but you have to do that work that changes that face. And I want to talk about that work. That work includes strengthening students against racism, strengthening them against challenges to their authenticity. You're not black enough. You're not Māori enough. Those sorts of challenges come up. Often students would have given up, or their parents or their grandparents would have given up belonging to tight cultural communities, and sometimes you might have to help strengthen their culture. And you have to negotiate how to manage the internal and external leadership expectations upon them. These cohorts have begun specialist training, but they're not really the big cohorts. You can expect them within the next 5 to 10 years. Now, I just need to stop a minute and go back to talk about the pipeline. The success in our workforce development has come about by taking a pipeline approach, by acknowledging that we are part of societies and communities, and that our society is racialised. And that even if you have come from a strong Indigenous community within that, there are barriers in our racialised society. Those barriers relate to what access we get to good education, to different schools, to schools who are able to prepare students to go into medical school. And we won't even talk about schools themselves, who can teach down to Indigenous students and have lower expectations. Our recruitment strategy reaches into schools. Our messages to Indigenous students in schools is science is Indigenous. There is such a thing as Indigenous science, but we have a right to access all the science of the universe. Science is fabulous, and science is our future career. Keep studying science, despite what your teacher tells you. We provide support and access for successful study and exam success. We support informed choices for career development, and we support work with families and communities about what expectations, or what they can expect and how to manage their expectations. The next part of the pipeline we have is we provide Bridging Foundation program. Very few schools produce Indigenous students who are ready for tertiary education, and many do not provide a strong background in all three sciences ready for medicine. And we also have to provide a pathway for those Indigenous people who want to return to study. During the undergraduate program, we work hard to ensure cohort cohesiveness. We have lots of, I suppose you would call them camps, or getting away together, doing team building exercises, having fun together, sports, etc., and cultural activities. We provide safe spaces where you can be black. We build cultural strengths. We help them manage racist discourse that they meet in their class. I might tell you one just happened. I just got an email yesterday. And we provide heaps of academic and pastoral support. Now the pipeline extends out into postgraduate and specialist training. It's prompted with alignment with the AMC accreditation standard, which has helped bring Indigenous health and Indigenous workforce development into focus. My words of warning are, firstly, it's not a snatch and grab. We need to, as members of colleges, we need to really care about Indigenous graduates. It's not about who can get the best, most, first, more, now. It's about mentoring all graduates about their future careers, their passions, their work, their families. Their career development is imperative. Don't sell your specialty. Hey, sell mine, no. I'll hold that back. Help them build their career. Tempting as it is, don't think you know what we need. Don't put forward your expectations. What we want is an Indigenous medical workforce that wakes up every day excited to go to work and committed to good practice. We don't necessarily want everyone to work in Indigenous communities. We need heaps to work there, but we actually want people everywhere and need people everywhere, and we want people to be passionate about their work. We don't want you to burn them out. My advice to colleges is first and foremost, create a safe college for Indigenous doctors to join. I would call yourself a patient. Do an examination. Do some tests on yourself. How culturally safe are you? Are you ready? Make a plan and make changes. My second piece of advice would be to take a long-term view. The key is flexibility, and cohorts are powerful and safe. Kia ora.